So IL-17 is a cytokine that is important in both the skin and the joints, and so it is a pivotal cytokine for both psoriasis and psoriatic arthritis. So we just heard a lot about IL-23. One of the ways that IL-23 functions in the pathway is that it induces the production of IL-17 by Th17 T cells. So we can think of IL-17 as sort of being the cytokine that is right at where the action is. So the IL-17 is acting on the joints and it's acting directly on the keratinocytes. IL-17 induces the production of antimicrobial peptides, which we know are important in the skin in psoriasis. Neutrophil chemoattractants. So when we look at the histology of psoriasis, we see Monroe's microabscesses. Those neutrophils are being brought in, and IL-17 is important in that pathway. Also in dendritic cell and T cell chemoattraction as well. IL-17 directly induces the proliferation of keratinocytes. We're going to hear more next about psoriatic arthritis, so I'm not going to go into that because I would certainly not do it justice. But the other thing that IL-17 does is it promotes osteoclast activation. And so this is how you get the bone destruction that is associated with psoriatic arthritis, and something that we've learned is so important in terms of treating our patients, that this is what we need to prevent. There are a couple different strategies for targeting IL-17, or the IL-17 pathway. So IL-17 functions as a dimer. It can be a homodimer, where you have two of the same subunits dimerizing, or you can have a heterodimer, where you have two different subunits. So the two ways that we are now able to target IL-17 are, we have antibodies that bind to the IL-17A subunit. So that's going to inhibit IL-17A and the IL-17AF heterodimer. And then the other way that we can do this is by targeting the IL-17 receptor A. And so that is going to more broadly inhibit the IL-17 pathway. It's going to inhibit the binding of IL-17AF, the AF heterodimer, and C and E. So I'm going to talk a little bit about the different drugs that we have. So we have 3 different drugs. I'm going to go over what they are, how they work, and a little bit at the end about some of the special issues related to these drugs. So the first one is Secukinumab. So this is a fully human monoclonal antibody, and this is to the IL-17A subunit. And it's FDA approved for the treatment of both psoriasis and psoriatic arthritis. One thing that we'll see is that the dosing is a little bit different for psoriasis versus psoriatic arthritis. We actually use higher doses of medication to treat psoriasis. And there's also the psoriatic arthritis dosing has an optional loading dose as well. So there are so many studies of all these biologics. I could spend 2 hours going through clinical trials. I will not do that on Friday afternoon. What I have tried to do is pick the studies that I think give us good information, specifically ones that have a comparator to the drugs that we have a lot of familiarity with. So the first one is the FIXTURE study, which is in psoriasis, and this is Secukinumab versus etanercept and placebo. And so what we can see here is, if we look at looking at responses of IGA 0 or 1, we see one, that Secukinumab is definitely more effective at the 300 milligram dose, and we can see that it is more effective than etanercept, and also, as expected, very low placebo rate in the first 12 weeks, which was the placebo-controlled period. We're used to looking at PASI 75 data for drugs, and what we can see here is, if we look at the PASI 75 response at week 12, which sort of tends to be the number we all think about, for the Secukinumab 300 milligram dose, it was 77.1%. For the 150 dose, it was 67%, and for etanercept, it was 44%, and placebo 4.9%. I think really incredible thing about these drugs is that we don't just think PASI 75 anymore, we think PASI 90 and even PASI 100. And so what we can see here is that we have significant PASI 90 and 100 responses, again with the 300 milligram dose, and again significantly higher than with etanercept. And now this is the CLEAR study. The great thing about the 3 drugs I'm going to talk about is that they all have an active comparator study with Ustekinumab. And I think we all have a fair amount of comfort with that. It's a drug that most of us have used and had found to be pretty effective. So the question is are these drugs better than sort of what we already had that was working pretty well? And so what we see here is looking at PASI. I'm just going to focus on the top 2 because really if our goal is to try to get patients, treat to target, get patients clear to nearly clear. We're looking at PASI 90, PASI 100 responses, and what we can see is that comparing Secukinumab at the higher dose of 300 milligrams to Ustekinumab, we have higher PASI 90 responses just looking at week 16, 79% with Secukinumab, 57.6% with Ustekinumab. The other thing is if we look at the early time points, so this graph, because it's only a 16-week, we can sort of see what's happening. The week 0 to 4 isn't all bunched up like it is in our 52-week graphs. And if we look at that, we can see that there's actually a superior PASI 75 responses early at week 4. So these drugs work very quickly. I am not going to go into excruciating detail because you're going to have a psoriatic arthritis talk, but this is looking at ACR 20. And again, like having a PASI 90 and 100, you're going to actually see ACR 50 data too, I'm sure. But looking at primary endpoints of a 16-week endpoint, ACR 20, we can see that the 2 doses of Secukinumab, including having with versus without the loading dose, they tend to actually have much more similar efficacy than what we saw with psoriasis, where the higher dose is consistently better. And these drugs seem to work better in our TNF-naive patients than our TNF inadequate responders, which are in that last graph. So I'm sure we're going to hear more about that next. The next drug is Ixekizumab. So this looks exactly like the other diagram that I showed you because this is also another fully human monoclonal antibody to IL-17A. And this is also FDA approved to treat psoriasis as well as psoriatic arthritis. And again, we have 2 different dosing regimens. So I'm going to, again, this is going to seem like a repeat, but I'm going to show you this drug versus etanercept and placebo. These are the Uncover 2 and Uncover 3 studies. This is 12-week data, so this is a pretty quick response here. And so what we can see is we're looking at Ixekizumab every 2 weeks versus in the green versus every 4 weeks in the red. And then we see in the blue the response to etanercept and in purple the placebo. These are 2 very similar studies. Published in the Lancet. What we see are very similar studies with Ixekizumab dosed every 2 versus every 4 weeks. Again, looking at the data at, these are PASI 75 responses at 4 weeks, we can see how much faster of a response we get than we do with the etanercept. And then this is looking at PASI 90 responses. Again, significantly better, similar with the 2 dosing regimens and significantly higher than what we saw with etanercept. And here we have it again, our Stelara comparator study, our Ustekinumab comparator study. This is IXORA-S. This is sort of the study design. It's Ixekizumab given every 2 weeks to week 16 and then every 4 weeks thereafter versus standard weight-based dosing for Ustekinumab. And so what we can see here, this is looking out to 24 weeks, and we can see that we have, especially initially, looking at PASI 75 responses, a little faster response here. These 2 by week 24 approach each other more so. However, when we look out at the very high efficacies of PASI 90 and PASI 100 responses, this is sort of where we see these 2 drugs differentiate from each other, and we see that we see the superior performance of the Ixekizumab. Again, just briefly on psoriatic arthritis. This drug is FDA approved. And this is great because this is an active comparator study that for the first 24 weeks included adalimumab. I think as dermatologists, I'm really looking forward to hearing the next talk because I feel like I can never learn enough about psoriatic arthritis. But one of the things I always take home in my mind is TNFs are the best. So, use adalimumab if they have psoriasis and psoriatic arthritis. It's going to help their joints most. And sometimes I would sort of want to default to that. However, this study would show very equivalent responses to adalimumab and Ixekizumab. So again, it tells us that we can target the IL-17 pathway, get that faster response, but still help our patients with psoriatic arthritis. And then finally, Brodalumab is our most recently approved drug. This one is the one that works a little bit differently. So this targets it's an anti-IL-17 RA. And so you can see here in the blue arrows, these are all the receptors that are inhibited. So if we look at Secukinumab and Ixekizumab, they're going to target the binding of these dimers to their receptor. Anything that, however, if you look at Brodalumab, you are targeting any of these interactions. So probably a little different mechanism. This is only FDA approved for psoriasis. I'll show you the psoriasis data. I'm not going to go in. There is some data in psoriatic arthritis, but I'm not going to go into it. Again, here's our Ustekinumab comparator study. So this is Brodalumab versus Ustekinumab. There were two studies, Imagine 2 and Imagine 3, and we could see PASI 75 responses here and then PASI 100 responses here. What the two studies showed extremely similar results here. The green is Brodalumab at the approved dose of 210 milligrams, and the blue is a lower dose of 140, and then the yellow or mustard color is Ustekinumab at its weight-based dosing. And so what we can see here is PASI 75 responses of around 85 to 86% and around 40-ish% looking across the two studies for PASI 100 responses at the approved dose of Brodalumab. And we can see, again, higher than what we see with Ustekinumab. And then again, looking at 4-week data, we can see this very quick onset of action. This is not a head-to-head study, but sometimes you get all these numbers, and it's hard to keep track of it and say, so how do they work? And in general, these psoriasis studies have similar inclusion criteria of 6 months of chronic plaque psoriasis, body surface area of at least 10%, and a PASI score of greater than or equal to 12. And so looking at, this was a study that aggregated data from different studies, and this is PASI 75, IGA 0 or 1, and then PASI 90 and 100. And what we can see is that we see similar rates across these, but again, with the caveat that this is not a head-to-head study. As I mentioned, this is these drugs, we can see just looking at the individual studies, the rapid onset of action. And this is a study where they went back and looked at the phase 3 studies for each of these drugs and looked at how long, at what week did they see a 50% reduction in PASI scores overall. So that gave us an idea of how quickly do these act relative to each other, and it gives us something that we can tell patients. So what we can see is that the longest time to onset was with etanercept, so 6.5 weeks to get a 50% reduction in severity, then Ustekinumab, adalimumab, and even surprisingly to me, Inflammatory had 3.7 weeks. I usually think of that as a pretty fast-acting drug, but it really doesn't compare to the, it's still not as fast as the IL-17 antagonist. So 3 weeks for Secukinumab, 1.9 for Ixekizumab, and 1.8 for Brodalumab. Okay, I'm going to now just transition, and I'm going to talk about some adverse events or risks associated with these drugs. As we've seen safety data across a bunch of these studies, we we all know that biologics do carry with it some increased risk of infection. We have not, an increased risk of malignancy, I think, was one of our biggest concerns in the era of the biologics. However, that has really not come to fruition. So it carries the same risk profile as some of the other drugs that we have. And as we get more long-term comparative data from registries like Corona, we'll have more ability to look at, what we saw with Solar Registry, where we can compare infection rates in patients on traditional systemic agents versus TNFs versus the other biologics. So I think that there'll be much more interesting data to show about that in a few years. So injection site reactions can be an issue. If we look at rates that have been reported, there's not a good reported rate with Secukinumab. Ixekizumab seems to have a higher risk of, or higher rate of injection site reactions, 13 to 17%, depending on which study you look at. And for Brodalumab, it's about 6%. This was on my way out the door yesterday, I saw this patient and got this photo because this is sort of a good example of a injection site reaction. You can see this edema, you can see the erythema. It's good to tell patients about this because I did have a patient who I got a message from my nurse that the patient wanted to let you know she was just discharged from the emergency room for IV antibiotics because she got cellulitis from her IL-17 injection, her Taltz injection. And, that was, we had to then make sure that we went back and said that actually was not cellulitis, explain what an injection site reaction was. It's good because then people don't get frightened. And these are not serious, and in the studies, none of them required drug discontinuation, and it's something that you talk patients through, and they generally will still continue on their drug as long as they're doing well with it. Okay, the other thing that we worry about is inflammatory bowel disease with these drugs. And so in phase 3 clinical trials, if we look, it's roughly about 1 case per 1,000 patient years. And so this was seen in Secukinumab in a very similar rate for Ixekizumab. Interestingly, Ixekizumab has been used in patients who had an IBD history, and so there were 16 patients with a reported IBD history in earlier clinical trials who did receive Ixekizumab. Most of them did not have any adverse events, but still a quarter is a significant number. So this is not a drug that we would use in a patient who had this inflammatory bowel disease. And I will also ask them about family history of inflammatory bowel disease. If somebody is genetically predisposed to it, this is not going to be my first choice of class of drugs. And then with Brodalumab, there was 1 reported case of Crohn's disease. Okay, and then with Brodalumab, there's this very special warning that we have, and I think something that gave us all a little bit of concern when we, for those of us who were doing the studies or when we first read about it, which is suicide, which is something very new for us in dermatology to have to think about this. This is a recent publication in JAD in January, looking at the Brodalumab suicide cases. So there were 6 cases of suicide across Brodalumab trials. 4 of them were in psoriasis, 1 was in an RA trial, and 1 was in a psoriatic arthritis study. And so this is sort of the data going over what were those cases. One of those cases has been determined to be potentially not truly suicide, but an accidental opioid overdose. Looking at it, these were all males, which is, this is sort of the age, this 39 up to 56, or 59, sort of the age in which we see suicide. Men are definitely more likely to commit suicide in the general population. This was the group in which we saw it. Interestingly, most of them had a very good response to Brodalumab, so it wasn't, these weren't patients who were having, getting frustrated with their persistent skin disease. If you read through these cases, there were psychosocial stressors involved in every case. I think, probably in any case of suicide, you can probably look back and find those. The FDA did did go back and so when this sort of came out, the clinical trials for brodalumab were actually put on hold and eventually shut down. So this was a concern. The FDA did go back, analyze the data that was available in 2015, and they determined that there was no established drug-related risk of suicide or suicidal ideation. As we know, this is now an FDA-approved drug. This is now on the market. To date, there's been no additional data correlating brodalumab in suicide. There is a REMS program in place in which if you do want to start a patient on this drug, you have to counsel that patient. You and the patient have to sign a form going over the fact that the counseling took place, that they do understand this risk, and then once that is done, you can prescribe it. We are all, I think, a little gun shy of REMS programs because of iPledge and because of the burden that it can put on us. The REMS program for brodalumab is actually quite simple. It's a one-time form. It is not a recurring one. Certainly, if you do have patients on brodalumab, it is something that you want to ask about at each visit, though, and screen for. So this is interesting. This is an analysis. So as I showed you, we do have a head-to-head comparison study of Ustekinumab and brodalumab. And so there's a period where you basically randomize patients, and some got Ustekinumab and some got brodalumab. There are far fewer on Ustekinumab, and there's less time follow-up, adjusted patient years of follow-up with Ustekinumab. Depending on how you define everything. Suicidal behavior, you could say that there were similar rates in the two groups. Intentional self-injury, similar rates. All of these 95% confidence intervals overlap. However, really the only group that had a completed suicides in this active comparator controlled period was brodalumab with 2 suicides. So overall suicidal ideation and behavior was similar in the two groups, but there was only the completed suicides were only seen in brodalumab. And so one of the questions that was looked at was, well, is this just, is this suicidality sort of its own unique event, or is it that all these patients are getting more depressed or they're getting more anxious on brodalumab? And so this was looked at. So they looked at patients in a placebo-controlled period, patients on placebo versus patients on 2 doses of brodalumab, and they said, what happened to their depression and what happened to their anxiety? So these were all measures that were being collected as part of the clinical trial, sort of independent of the suicide concern. And they looked at it's the dark blue. If they improved, they got less depressed, less anxious, and the aqua blue if they were worse. And so what we can see is that you actually see a greater separation of this in patients who were treated. So they were more likely to improve and less likely to worsen if they were on brodalumab. So it's probably not that the drug is, and that's probably because of the skin. The hypothesis is that's because their skin's getting better, but it's probably not that the drug is causing widespread anxiety and depression. So I look forward to learning more about this at some point. I think we don't have a good grasp on, sort of the relationship between what makes somebody suicidal versus what makes, versus depression. And there are lots of depressed people, but very few suicidal people. So I'm guessing that there's a little different mechanism at action there in play too. And then finally, the other thing that we will encounter are Candidiasis and tinea infections. So, biologically, this is a plausible side effect of this class of drugs. So there are people who have congenital IL-17 deficiency, and there are people who have gain-of-function STAT1 mutations, chronic mucocutaneous candidiasis, that causes impaired IL-17 production. And we know that these patients do get increased candida infections. And in fact, the incidence of mucocutaneous candidiasis was 3 to 4% if you look across these studies. Highest incidence, but much lower number of patients overall was brodalumab. And fortunately for us, there really was no evidence of systemic or disseminated candida. So these were treatable infections. These were superficial infections. When I see patients on IL-17 drugs now, I have them open their mouth and I look for thrush, because that's sort of one of the most common ones. Women will generally report to you if they're having vulvovaginal candidiasis. So these are the things that we can look for. And I see I'm out of time, and that's, so I'll just end here. Long-term data, we are just starting to get 4 and 5 year long-term data. We really have it just for Secukinumab and Ixekizumab. If we look at the same analysis of last observation carried forward, if we look at the PASI 75 response, we see that about 80% of patients maintain that at 4 to 5 years. So these do seem to be drugs that are durable. And there were no new safety signals in either drug. So I think those are very reassuring data to have. In conclusion, when should we consider these drugs? Concurrent psoriatic arthritis, particularly the two with the indication, desire for rapid onset, and when they failed other agents, when do we want to avoid them? Patients with inflammatory bowel disease or a family history of it, and patients with severe depression or suicide attempts, particularly really applying to Brodalumab.